Thank you so much, Ella. It's just a privilege to be here. I mean, everybody on this call is heroically working to support the people who need it most in this country at the perfect time. So I feel really fortunate to be here with you all. Thank you so much. I'm going to share what we're doing at CareSignal. We are, as you will see, we're fanatical about accessibility and scalability in order to drive clinical impact and then financial sustainability. I'm pretty humbled to share. Actually, this is the first time we've shared this publicly. This year, CareSignal will touch more than 1% of U.S. adults across the U.S., largely safety net populations. We have tens of thousands of active individuals at FQHCs, Medicaid plans, and a number of other large payer and provider groups across the country every single day. So before I dive into what CareSignal is doing, let's talk about the why, which is specifically, I think, we hear RPM, and usually we think about investing in the high risk part of a population, the top of my metaphorical iceberg here, right? And that's good, but in order to really bend the cost curve sustainably, and in order to scale the clinical capabilities that are already in place with your teams, we also need to look at the rising risk population. And a few different recent publications have defined this really effectively, and have also shown that that's the path to cost-effective and sustainable remote patient monitoring engagement in the long term. And exactly as Ella said, and I think, Dr. Chavez and Dr. Braid prefaced this as well, there's kind of this dance that we're doing, right? On the left of this Venn diagram, you have traditional RPM, which is great, but expensive and sometimes can lead to more tech support and implementation issues. And on the right is patient engagement. CareSignal is deviceless remote patient monitoring. Think of us as very roughly 100 times more scalable than a device or connected device approach at 10% the cost, but with all of the same clinical actionability. And what that winds up leading to is the ability to penetrate deeper in a population than would otherwise be possible. In terms of the how, well, I mean, we have a running joke that nobody can escape CareSignal. We use the technological common denominator. Text messages, phone calls, we can go through a concerned caregiver if a patient isn't comfortable asking or responding to questions. Now, here's the other part. A lot of our populations that we're discussing here today don't have unlimited text message plans, even if they do have cell phones, and just about everybody does. So CareSignal has formed relationships with all the big cell carriers, so we can push messages through for free and receive them back for free, even when a phone runs out of minutes. And of course, meeting people where they are means more than just technology. It means language, it means cultural sensitivity, and we support English, Spanish through to Bosnian is the most obscure language I could find that we have active right now. Now, just to hammer this home, right, accessibility really is king. We want to make sure that from a health literacy and even just a true literacy perspective, we're meeting folks where they are. Tech perspective, cost should never be an issue. And then we need to drive long-term engagement using that familiar technology. Now, there's another challenge that I really want to discuss, which is, a point solution for a given condition, even the most worthwhile conditions right now, diabetes, heart failure, hypertension, is just that, as a point solution. We take a portfolio approach. So in the upper left here, you see exactly what we're discussing, right? The big three, the common offenders, and then of course COPD, asthma. You can imagine that the pulmonology side is pretty adjacent to cardiometabolic. But CareSignal also supports behavioral health, social determinants of health. In fact, we now have more than 11 modules across the SDOH spectrum, maternal health, including breastfeeding adherence, such as for new mothers on Medicaid, and then a variety of complementary and supplementary programs, each of which is evidence-based. And when we started the company, we recognized that technology isn't really, the hardest part. The hardest part is capturing sufficient clinical and financial evidence that we can help often slow-moving industry to see that there is a way to, with positive ROI, to adopt new tech. And that's led us to conduct more than 5,000 patients worth of IRB randomized controlled trials and quality improvement studies. We've now published 10 peer-reviewed articles in different medical journals showing these reductions on the screen. And just a fun one to highlight, even though it's a little bit out of scope for this conversation, our COPD randomized controlled trial was one of the first, if not the first, placebo-controlled trials in digital health. where we even controlled for the Hawthorne effect to make sure that the impact that our technology was having was really its impact and not just, an observation effect, which could be then compounded by a regression to the mean issue. All right, so we're gonna take a quick beat here, walk through the CareSignal workflow. I'll share some of the partners with whom I'm privileged to be working across the country, and then time permitting, I'll talk about our team and a couple of quick case studies. When you think about the CareSignal workflow, it all starts with a list of eligible patients. We work with our partners to figure out not just the high risk folks, but the rising risk. And once we have that list of eligible individuals, that's provided to CareSignal. And again, we can do this standalone, but certainly prefer EHR integration. We really love our partnership with Redox for Epic Cerner and just about everyone else. Then our team reaches out of engagement specialists, reaches out white labeled, and enrolls those patients. And this team is 11 part-time people right now. They'll make 6,000 to 12,000 calls to patients and members across the country this week. And we're reaching out to educate these patients or members on this new free program that their provider, even a specific care team provider, has for them to keep their heart healthy, to keep their blood sugar in check, to keep their mood well managed. The patients then enroll and begin interacting with our automated technology. Remember, accessible, scalable, automated. That's where the text messages and phone calls come in, even for populations that have pay-as-you-go phones. And as those responses are provided by the patients, the patient-reported outcomes, blood sugars, breathing day over day, mood, pedal edema, nocturnal dyspnea, all at a fourth grade reading level, then CareSignal can do one of two things. One, if we're integrated with the EHR, we can inform the existing workflows of those care coordination or care management teams, and that can be escalated to providers as necessary. Two, for groups that maybe don't have the operational and clinical infrastructure that they would need, we can use our own virtual care navigation team to supplement that care management, especially as that group is stood up within our partner. It's an analogy here that the tech folks will chuckle at, but this is kind of like having cloud flexibility before you bring something on-prem. And sometimes it winds up being more cost effective to keep it in the cloud for the long term. So, we're doing this with a variety of organization types. The common denominator across all of these groups is really the type of patient or member population. It's generally a rising to high risk population, lots of safety net representation. And there are some logos that I can't put on here, but some really large payers and payer provider joint ventures, as well as some really large Medicaid plans, including in the south of the United States. And these groups are all pursuing the same thing. How do you keep tough patients engaged as it relates to their chronic conditions for the long term? Which brings me to perhaps my favorite part before I go into a quick team and case studies. CareSignal has phenomenal engagement. I mean, we're really good at activating folks because we have that human touch up front. But after that, our half-life for this challenging population, just without anything else, is about 1 year. About 50% of folks stay engaged for a full year. But we're doing even better than that. So we have CareSignal AI, and I don't have time to go into too much depth, but CareSignal AI is able to predict which patients will disengage from our own technology with striking accuracy, 90 and 92% accuracy. And then our engagement specialist team can reach out and prevent about 57% of patients from disengaging that would have otherwise. And the kicker here, I think this is kind of evidence that preventative care really does work, is it's actually more cost effective for CareSignal to do that preventative re-engagement than it is to enroll new patients from scratch. So it benefits the patient, of course. It benefits our partner because they have better engagement with the existing population and can scale more confidently. And it benefits CareSignal too from a unit economics perspective. So CareSignal AI has been a boon. Now, something that I think Adaptation Health is rightfully focused on is the importance of equity and diversity. I'm really pleased that CareSignal is more than 50% minority and female as a team. We conduct yearly reviews to make sure from a salary and equity compensation perspective that there is gender parity, which is a passion of mine, frankly. And I'm really pleased to work with my founding team as CareSignal scales. All right, so now we're going to shift into a few quick case studies to give you a sense of exactly how flexible we are at scaling deviceless remote patient monitoring to different population types. I'll actually start here with the largest federally qualified health center in Colorado. In Colorado, we're privileged to work with Stride, a very large behavioral health provider, and other organizations supporting all safety net populations. This is kind of a prototypical use case. It starts with just one or two conditions, diabetes and hypertension, scales from there. CareSignal does all of the outreach and enrollment, and the existing care management team is able to scale their reach, billing for codes when possible, but driving quality, shooting for quality metrics that make this financially sustainable even while RPM isn't reimbursable. It shows in the data, and this is actually just the risk stratification data. But if we go up here to a large physician group based in St. Louis that was focused exclusively on CHF, diabetes, and COPD populations, not only were we able to ramp up to thousands of active patients in a matter of weeks, but CareSignal was then able to help this team scale from about 100 patients per care manager to about 1,500. The numbers don't lie. This team's own analysis showed a more than 10% reduction in total paid medical claims versus patients who were not on CareSignal. Even when you take into account the cost of the first event that made a patient eligible for CareSignal that could otherwise be a regression to the mean issue. And again, 46% reduction in CHF ED visits, 31% for COPD. I was really proud of these. I'll pause here to highlight yet another case study. We can kind of do this all day on the research and case study side, but that's right at time. I would love to answer any questions that anybody has.